So good evening to everyone. Thank you to AstraZeneca. Thank you, Dr. Narasimhan. Thank you, sir. Thank you, Shivasu, sir. My topic for the presentation is prostate cancer patient journey with a multidisciplinary approach and the GETUG AFU 16 sort of the trial and the inferences. So as we know, prostate cancer is ranked as the fourth most frequently diagnosed cancer worldwide. This is as per the 1.3 million new cases per year, making the second most frequently diagnosed cancer, second to the lung in males. And it's the fifth leading cause of death. So because of the prevalence, the number tends to develop into a castration resistant or the metastasis, and the death also is now sort of significant as the fifth leading cause. And there is a striking geographical variation. The Asian belt, especially with us in India, it's not as high as when we look towards the Western Hemisphere, in Brazil, in South Africa. The mortality also, fortunately for us, again, it's not in the high zone. The epidemiology. So from the Indian point of view, the prostate cancer ranks 16th incidence-wise in India with a reported incidence of 25,696 cases, and the deaths are 17,184. Almost all patients with metastatic prostate cancer go on to develop a castration-resistant prostate cancer, and the overall prognosis of the metastatic CRPC remains poor with a median survival of 1 to 2 years. Little is known about the prostate cancer etiology, but the increased risk appears to be associated with increasing age that we all know, the genetic and the lifestyle factors. There is an ethnicity, especially from the Western point of view, that the black race is more prone. There is a hereditary predisposition as well. We are learning more about it. The diet, the obesity, the cigarette smoking, yes, they are associated factors. So risk is higher in men who have a family history of cancer, similar to breast, especially if the father or the brother had a cancer or a prostatic malignancy. And simple, just a primer slide, what is the benign prostate hyperplasia and the prostate cancer? BPH refers to a non-cancerous increase in size. It's a physiological or a natural process. Prostate cancer refers to the cancerous enlargement of the prostate gland, and there are zones in the prostate which actually sort of dictate the symptoms and show it differently with respect to either of the etiology. So what is the common age group for prostate cancer? Prostate cancer is a disease of advancing age. There has been a statement that if all the males live beyond, say, 110 years, we all might be having prostate cancer. This was one of the statements from Johns Hopkins. The commonest age group right now, as per the detection, is 60 to 80 years, can occur 50 to 60 years, rarely less than 50 years of age. Yes, there are cases, but yes, the commonest age group is 60 to 80 years. And there are two categories of patients, especially with the screening programs. One is that we find a raised PSA as a routine test, or there are symptomatic, there are sets of symptoms with the LUTs, we call it the lower urinary tract symptoms. If the zone is on the posterior side, can lead to constipation, retention of urine, difficulty in passing of urine. And if there is a metastatic disease, or if there are sort of a systemic spread, then we see sort of a weight loss, generally tends to involve the lumbar vertebrae, the pelvic bones, and with the loss of appetite. So we can sort of think in those lines from the syndromic point of view that it can be either a locally advanced or a metastatic presentation. The examination begins with the general examination, the performance status, weight, the distal rectal examination to sort of think or to find out the size of prostate, the nodularity, consistency, firm versus hard. The BPH tends to be soft. The rectal mucosal involvement also is a part of staging, which sort of gives us a guidance towards the staging. However, the PSA, which is done as a blood test, has been used as a screening test also with a free and a total component. It is specific to prostate, but not to prostate cancer. As we all know, it can increase in a prostate infection, benign, the BPH, and the malignancy itself. And this is how sort of a rule of thumb that less than 50 years, the normal range is 0 to 2.5. 50 to 60, 0 to 3.5. There is a cutoff that is defined, commonly used as 4 nanogram per ml. We should do a free to total PSA sort of a distinction. 60 to 70 is 0 to 4.5, and more than 70 is 0 to 6.5. The investigations which are routinely part of the workup are the MRI pelvis, the impressions of benign versus cancerous enlargement of prostate, the PIRADS grading score, use of the diffusion weighted imaging as well. There are to find out whether there are single lesions, multiple lesions, location of lesions, the spread involvement to the surrounding structures, to find out the lymph nodes as well, because that upstages the disease, the condition of the bladder with respect to the long-standing urinary symptoms, sometimes on a background of the BPH itself. A truss-guided biopsy, minimum 12 biopsy samples plus a targeted biopsy from any lesion to find out both lobes which are affected so as to stage it as per the TNM criteria, the number of positive biopsy cores, the grade of biopsy from the Gleason's point of view and to assign an ISUP score, the PNI, the perineural invasion, which if it is absent or present. The steps of cancer treatment: as the diagnosis, we confirm the diagnosis, we stage the disease, we find out whether it's locally or loco-regional, then we do a metastatic workup. The PSMA PET CT is used, or a CT chest and abdomen. PSMA PET CT now, since it's getting readily available, it's sort of getting common and part of the routine workup. And then a combined information with respect to the PSA level, the TNM staging, the grade. So we stratify in terms of the risk stratification. This is from the basic anatomy. So the most common site of prostate starts in the peripheral zone, and also sometimes in the transitional zone, which causes a different symptom. But yes, peripheral zone is what is the location of the prostatic malignancy. The central zone is more for the BPH. So the main treatment modalities, if we look at numerous guidelines like EAU, NCCN, so we have to sort of risk stratify as low risk, very low risk, low risk. Early stage, we can go for active surveillance versus radiation alone, brachy versus a radical prostatectomy. The intermediate stage, I'll just show that in the next slide. We can go ahead with either radical prostatectomy to find out whether the chances of lymph node involvement, then radical prostatectomy plus a pelvic lymph node dissection is the treatment of choice, versus depending upon the age, the life expectancy, we can sort of start on the hormonal therapy, and versus radiation alone. There is the high risk cancer prostate, a very high risk cancer prostate, and then there is a stage 4 metastatic disease for which a lifelong hormonal therapy versus bilateral orchiectomy, the agonist versus the antagonist that we've already discussed. So the hormonal therapy, if we see, it always forms the backbone for the all stages of prostate cancer because it is hormonal dependent. That is why. So it comes into the picture from the logical point of view, which has been tested and sort of been validated in trials. From the radiation point of view, I'm being a radiation oncologist. Sorry, this slide is slightly a prior slide, but we've got good technologies now. Sir has seen, Dr. Srivastav sir has seen the evolution of radiation to start off with just the bony landmarks, but things have improved. We can now see everything. We can modulate our dose. We can literally dose paint with respect to the target, the prostate, the lymph nodes. We can now achieve a higher dose to the prostate, to the lymph nodes. There is a concept, a theoretical concept known as stereotactic body radiotherapy, where we can give a higher dose, which also has an anti-angiogenic mechanism, so as to give a better biochemical disease-free recurrence. That is how the endpoint of SBRT has been evaluated, which actually or sort of is a surrogate marker for overall survival. Different types of technique started off with 2D, the bony landmarks. Then we came on to the conventional radiation look, as if we can all appreciate the dose cloud or the dose. It's just like treating APPA. The four fields does help to reduce, but yes, the tissues are quite sort of, the OARs are sort of getting irradiated. Then comes the intensity modulated radiotherapy, with which we can sort of dose paint, giving a mathematical problem to the to the planning system with which we can get a very tight and a conformal dose to our targets and sparing of the normal tissues. So as you can see, prostate and the lymph nodes are sandwiched between the bladder and the rectum. So this IMRT gives us improved conformity, improved clinical outcomes. In fact, IMRT was the technique which was tested in prostate by Michael Zalewski et al. In a randomized controlled trial, which increased the overall survival, the hardest endpoint, with less complications, lesser side effects, the image guidance with the role of the cone beam CT also helps. So this is the IMRT, as we can see, conventional radiation, and we can very well conform, save the bladder and the rectum and the bowel bag. The cone beam CT, the CT scan, which is attached onto the machine itself, has been a boon. It takes a picture there, takes into account the setup errors and rectifies it. It also can deliver the plan of the day if there is a different bladder filling or there are different rectal states, whether it's full versus empty. So these things can be taken into care to increase the therapeutic efficacy, to increase the tumor control probability is what we radiation oncologists say, and to reduce the normal tissue complication probability. So this is how the planning CT looks. We acquire a cone beam CT, we fuse it, we co-register to the planning CT. We find if there is any difference. There are 6 degrees of freedom that can be corrected. There are a multi-leaf collimator concept which can fine-tune the beam. There is a triple F beam, a flattening filter free beam. So the end point is to achieve a higher dose to the target and minimal dose to the organs at risk. The current radiation therapy for cancer prostate has been 60 to 65 gray over 4 to 5 weeks. Earlier, it was 2 gray per fraction. That is our conventional fractionation, but we have started hypofractionating also from a radiobiological point of view. There is an alpha by beta concept in radiobiology, which is low for the prostate. That means it will respond to a higher dose per fraction. And then we have extrapolated that alpha by beta concept into giving a very high dose, like a 6 gray or a 7 gray, which we call it as stereotactic body radiotherapy. But these kind of high doses should not be attempted with the 2D, the bony landmarks. Otherwise, the organs at risk, they will suffer, and we will have inferior outcomes with regards to the toxicity. So the higher dose, as I said, by the IMRT was shown to improve the person PSA relapse as you go up the ladder. That is, if you increase the dose, you get a better PSA relapse-free survival. The grade 2 rectal toxicity also depends upon the technique, but it tends to get with more intensity modulation and more technology use. The cystitis and the proctitis, yes, were there with 3D CRT, even with IMRT, but the rate has been coming down with a lot of intrafractional imaging, the plan of the day implementation. So it's how you put into the plan so as to get the better result. The grade 3 toxicities have been coming down with intensity modulated radiotherapy, with which we are sort of confident enough to give a higher dose, or think of higher dose in a hypofraction or an ultra hypofractionated manner. And then the use of hormonal therapy have improved the recurrence-free survival, the case-specific mortality rate. Things have sort of improved with respect to both the radiation as well as the hormonal therapy. Also, once we look for a patient who is post-radical prostatectomy, 2 recent trials, radicals and raves, and then a meta-analysis with the GETUG trial, the ARTIST meta-analysis, they have sort of thought upon this, and they've come to this inference that we can look on to with a regular PSA surveillance and keep the radiation as a delayed salvage option only when the PSA rises. So surgery also, this is with respect to the high risk patients that we have achieved a good biochemical sort of, I would say, recurrence free sort of zone. So the commonest that we have been using in our practice has been from a Fox Chase cancer PSA definition of rise of 0.2, which has been widely used and widely practiced. That is what we have seen, or with 3 consecutive rises once we are looking at 0.1 nanogram per ml. All lymph node positive patients, once we have done radical prostatectomy, should be given post-operative radical radiotherapy, that is irrespective of the post-op PSA. This point, I'm sorry, this I would like to put an asterisk, because as per radicals rate, this is debatable. That is, we can still keep the patient on hormonal therapy and wait till we get a high PSA level. The hormonal therapy, Dr. Mahindra has discussed the options, the agonist, the antagonist, orchidectomy, anti-ADT, which should not be used as a single agent, and the CYP inhibitors. Monthly versus a 3-6 monthly depot. Majority of randomized trials done prior to GETUG were done with a monthly preparation. There was a level 1 evidence. The 3 to 6 monthly depot was thought of to sort of take care of the to reduce the number of hospital visits, to provide ease to the patients. There was some concern prior from an hypothesis point of view that there might be some irregular release, or it might not be effective in decreasing the PSA. Side effects of androgen, the orchidectomy suggested by Dr. Huggins and Higgins they have received Nobel Prize for that, and it prepares your patients for the hormonal therapy. But as Dr. Mahindra also showed, and with bilateral orchidectomy, I was going through some literature that it might lead to castration-resistant prostate cancer. There have been a lot of metabolic disorders and also the psychological impact that it has. While the patients are on hormonal therapy, they have to watch bone health by bone densitometry. They need to take the calcium and the vitamin D. We encourage the patients to do physical activity and exercise. Bisphosphonates versus denosumab, that can be an option. The cardiac issues also need to be taken care of because they have a cardiac toxicity profile. So once a echo and ECG, and a 6 monthly lipid profile and diabetic profile as well. So patients presenting with locally advanced localized prostate cancer can be offered curative treatment. We need to find out whether there is no biochemical recurrence. Surgery versus radiation can be competing. Once we find out that the patient is castration resistant with respect to the testosterone levels, we switch over to the systemic therapy, which can be docetaxel or the abiraterone. That needs to be dealt with the medical oncologist. However, if we see the prognosis, now there is a stark difference. The stage 1, 2, and 3, if we see the relative 5-year survival by stage, for stage 4, it falls drastically, if we can sort of appreciate this fact. So we need to do something with respect to the systemic disease that needs to be taken care once we see these values. Similarly, from the Gleason's and the ISUP grade point of view, the recurrence-free survival, we see there is a fall, no doubt about that. There is a discrepancy here, but with respect to the ISUP and the Gleason, it falls, sort of comes down drastically. And prostate, as we all know, and even the malignancy is hormone dependent. It's a disease characterized by multiple clinical states. We plan for adjuvant treatment. The serum PSA is the most sensitive indicator. That's why we keep on repeating it. We then tend to find out whether it has become metastatic in the event of it being hormone sensitive, or it has become a castrate resistant, and then we decide accordingly. But these arrowheads show that these are the time points that we need to consider the systemic therapy. These are the definitions as per the NCCN, ISMO, and EAU. More or less same. I tend to practice the NCCN, but EAU more or less it's within the same sort of guideline framework. I'll just go through these slides quickly. For the low risk, once we have characterized the patients as low, intermediate, high, now there is a very high risk, as we can see from the NCCN guideline. We sort of tend to define. We watch for the life expectancy. There are life expectancy tables. You calculate them. You sort of give them an option of the active surveillance versus active treatment. Radiation, yes, a competing technology. Others like cryotherapy. However, there's no randomized trial. I checked it out. That says, but yes, it is mentioned in the NCCN guidelines as well, and EAU as well. Intermediate risk, again, if the risk of the lymph node exceeds more than 5%, then I myself as a radiation oncologist would advise the patient to undergo surgery. If required, the salvage or the adjuvant radiation therapy will come later. High risk, this needs to be understood that what is the evidence. The level 1 evidence still goes in favor of hormonal followed by radiation. However, a SEER database analysis, we have a Scandinavian trial which is running and which will give us the answers with respect to high risk, locally advanced. But whenever I try to find out the hormonal radiation still stays as category 1 in from the guidelines as well. But yes, a CR analysis recently in 2021, it's a retrospective data analysis. They've just come up with that, which says that yes, surgery can reduce the prostate mortality due to the cancer specific mortality. That is what they mentioned. However, the Scandinavian trial will give us the actual results. The locally advanced, again, the lymph node dissection is an option along with radical prostatectomy as part of the multimodality treatment. So the surgeon has to tell the patients that we need to keep on monitoring, you keep you in surveillance with respect to the PSA, and you might require radiotherapy. That is how things would be. First line metastatic patients. Now there is talk about the prostate being an oligometastatic disease. However, still the TNM does not categorize it as oligometastatic. Only the lung is categorized as oligometastatic. So there are two categories, either symptomatic patients or asymptomatic. For symptomatic, you start off with the systemic therapy. If there is any local problem like a bone mets causing a cord compression, then a neurosurgical intervention versus a radiation intervention, or a hemostatic RT. If there's a bleeding prostate, the radiation needs to be given along with the systemic therapy. Even for M1 asymptomatic patients, if the disease is in the weight-bearing bones, and if the patient is sort of motivated, then yes, the radiation can be given. Also, the LHRH agonist versus antagonist can be offered to the patient. With respect to the castration resistant prostate cancer, you need to confirm it with the testosterone level. You need to go ahead with docetaxel, the second line with abiraterone, cabazitaxel, give the best supportive care. Now, these patients don't fare well. So even the prostate is a slow growing disease. Once the patient comes into this picture, then things become really difficult. Then what is the aggressiveness of the disease comes into the forefront. So these are the EA recommendations with treatment of the bone disease, specifically to use zoledronate or denosumab. With respect to the skeletal related events, to offer calcium and vitamin D supplementation to treat the painful bony mets, depending upon whether it requires a surgical intervention versus radiation. And cord compression, again, surgery versus radiation, we have to take a call on that. Prostate cancer, it tends to start off localized. Patients do stay well. We have good results in prostate, but when they start progressing, they can become locally advanced, and then this is the dark side to the prostate cancer. So the GETUG trial wanted to try out. They randomized the patients in high risk patient stratified patients, in which they did radiation alone versus the goserelin, 6 months goserelin. The primary endpoint was progression-free survival, and the secondary endpoints included the overall survival and also the metastasis-free survival, the distant metastasis-free survival, and changes in the quality of life. The primary analysis conducted at a follow-ups of 63 months, and long-term was also going beyond 110 months, 112 months. So the progression-free survival was better with goserelin and radiotherapy, telling us that the disease has a systemic nature, and also the hormonal therapy acts at the local level as well. There was a 46% reduction in the risk of the progression or death with adjuvant goserelin post radiation. This forest plot has been shown by Dr. Mahendra. The IMRT crosses to the other side. I think we have improved on this IMRT line, and now the IMRT along with the goserelin should be to the left of the baseline. The RTOG 8610, again, Dr. Mahendra showed this with respect to the TROG. The primary endpoint here was loco-regional control and not the progression survival. And again, the TROG 9601, which again was time to local failure and prostate cancer specific death, primary endpoints. Time to biochemical failure was again with respect to the PSA. The disease specific mortality with the RTOG 8610 trial was favoring the goserelin. They also used an androgen plus and radiation, and was sort of favoring the goserelin, the hormonal therapy, and the radiation arm. There was also a 51% reduction from the TROG study as well, which was again significant with respect to the 6-month arm. Overall survival, however, as Dr. Mahendra also showed, again, was not significant. However, there was a trend towards the goserelin and the EBRT sort of that it was showing some improvement, and the all-cause mortality was definitely better with the 6-month neoadjuvant goserelin. So giving hormonal therapy prior to radiation, 3 months versus 6 months. So that also the TROG 9601 helps us from that point of view. The ASCEND-RT trial, this is from the radiation oncologist perspective, whether we can increase the dose. However, again, if we are getting better on the local side, we might fail systemically. So the hormonal therapy still remains as a core component of the treatment. The EUA guidelines therefore recommends for locally advanced to give external beam along with long-term ADT. The EORTC, the BOLA trial, which again Dr. Mahendra showed, and there are several randomized phase 3 trials which have promoted the combination of long-term adjuvant ADT as a standard of care. Long-term ADT produces at least shows an increased OS as per the RTOG 8610 and definitely reduces the death due to the prostate specific mortality. And this is what again from the AstraZeneca team, that they've shown that RT plus LHRH shows a better overall survival. That is how things are. Thank you so much. Thank you. This is the end of my presentation. Thank you.
Thank you, Pranav. Thank you. It was very nice.
Thank you, sir. Thank you.
Very comprehensive, and you have covered practically every aspect in that.
Thank you, sir.
I'll ask if everybody wants to ask some question or somebody. I could not see anything in the question answer chat.
Sir, can I, Srivatsa here, can I ask Dr. Pranav a couple of questions?
Please, sir.
Yeah, please.
Thank you.
Yeah. Extremely good presentation, lot of information, summarized in a nice manner and put across. Thank you very much.
Thank you.
My first question is regarding early salvage radiotherapy by radicals and rays, you know.
Yeah.
So how comfortable are you not to give adjuvant treatment in the basis these trials now in node positive patients?
I would say with respect to the node positivity rate, and again, if I look from a critique point of the radicals and raves, which came up from D. Amico et al., they were of the opinion, and this is what I quote and unquote, and that is why I still practice, if the node is positive, that is, I would like to give an early salvage, or for that matter, even adjuvant radiation, that there is a chance of it developing into a metastatic disease. So for a nodal positivity, yes, I would like to initiate radiation sooner than rather waiting on even on the biochemical parameters, that is the PSA.
Okay. Do you consider, so in our practice here, what we do is for up to 2 nodes without any extranodal extension, we tend to wait, looking only at the PSA. And then kind of put them on early salvage radiotherapy if required. That I personally feel really segregates those patients who will continue to remain cured because of the lymphadenectomy alone, versus not knowing whether the lymphadenectomy helped or the systemic therapy with radiotherapy helped.
Right.
The second point, which has been of some good consideration in the recent past, is the utility of certain genetic tests.
Yes.
For instance, Prolaris, right, or Oncotype DX, or Decipher, wherein you can actually run these tests in this subgroup of patients, and kind of see if they have a higher chance of recurrence or not. If these, I agree that these are expensive, but this is probably a good use case scenario where you can do these tests and see if they fall into the high risk category, go ahead with adjuvant treatment. If not, then just hang around and prefer to do the early salvage. What are your opinions on that?
I have not seen in my practice or neither practice these genetic markers, Dr. Narasimha, but yes, gone through the literature, the theory, yes, it makes sense. If I may just point out the trial design of radicals and raves. So treating a high risk or a very high risk patient, there wasn't, I'm just asking, I'm not asking as a radiation oncologist, as an oncologist, if I say, there was no level 1 evidence of patients being subjected to surgery. But yes,
No.
it was done. But the hypothesis itself was to start off with surgery and then to look for the biochemical recurrence thing. Now, if you look at trials prior to the biochemical recurrence failure, everyone was looking for metastasis-free survival, loco-regional control, progression-free survival. Once we got the biochemical recurrence free, the PSA, yes, things have gone on to that. Now, again, a recent trial, I'm just quoting from Tata itself, from Dr. Vedang Murthy, which is comparing pelvic versus just the prostate alone for the high risk, is looking at PSA. And however, there are two critiques to that. They say no, that recurrence, that indicator is not a very hard surrogate endpoint for overall survival. So you start looking for, again, progression. So we are again reinventing the wheel, going back to progression-free survival, the distant metastasis-free survival. So that is a critique by Dr. Rahul Tendulkar that he's given to the JCO article. So the radicals raves built upon the serum PSA as one of the endpoints, the biochemical recurrence free, and to judge the salvage radiation, whether as early or delayed. But with respect to nodal, I think the DMICO critique of that article stands its own ground. I'm sorry, that is how I think of it. So nodal, two nodes, as you said, once we read the critique, I think it's a matter of decision then how we interpret the evidence. That is how I would say.
Yeah. Srivastava sir, can I have your opinion on this? 1 to 2 nodes positive, would you go ahead with adjuvant treatment, or would you still wait for the PSA to recur and then do a early salvage?
I think I agree with Pranav, what Pranav mentioned. So I think this is the common thing which is a dilemma for all of us. So I agree with Pranav.
Okay. The second point, Dr. Pranav, that I wanted to bring out is the role of multimodality therapy. I do agree that ADT and RT has level 1 evidence for high risk localized or even loco-regional prostate cancer, but we need to really look at how this level 1 evidence has come up. Yes. So this level 1 evidence is in comparison to ADT alone.
Yes, or even radiation alone, for that matter.
So so it is very hard to get a level 1 evidence comparing two curative therapies, and that's the same reason why we have not had a
exactly. So with in all humility, then we should wait for the Scandinavian trial for the results to come up, and then we employ surgery as a definitive treatment, Dr.
So I think
without any bias. Yes.
Yeah. So the bias. Yeah, I completely agree that there are going to be biases, but when we talk of this level 1 evidence, that was in an era where surgery was not uniformly practiced with the same standards. So I'm not supporting, I'm a surgeon, but I'm not supporting surgery here. What I'm trying to emphasize here is that there are several trials which have proven that multimodality significantly alters both cancer specific and overall survivals, which you also brought out in your
So we read one of our textbooks. I just want to quote is by Perez, Radiation Oncology, and every new edition, especially with respect to prostate, I'm just sharing it with you, there is a debate. the chapter itself mentions surgery versus radiation, especially in the high risk zone. So the trials which have been done, including the SEER database analysis, Joby 2021, which it has come, supports surgery, but that's a retrospective data analysis. All the prospective have been a phase 2 trials, which yes, do support surgery with respect to studies. But again, if we are a bookworm and if we have to go by the book, then we should wait for the Scandinavian trial. Otherwise, if I'm
Scandinavian trial that we are talking of is already
is ongoing
because of low accrual. So I don't think that the trial will complete its accrual and then we'll have some results. Again, it is not about whether surgery is better or radiotherapy is better in this regard. I feel both of them need to be employed to maximize the outcome. That is my take on this.
Right. I respect that, Dr. Nasir. I do respect that. Right.
I think Rajesh has some, he raised his hand. Rajesh?
Yes, sir. So regarding the question Dr. Srivastava asked regarding adjuvant therapy in node positive disease, I think you should take the local staging into consideration, high risk pathological features such as positive surgical margins,
Right.
terminal vesicle invasion, and extraprostatic extension, all these things into consideration, and grade of the disease, and nodes, number of nodes positivity, more than more than 2 nodes positivity, how bulky are the nodes, and any extranodal extension are there. So these are the things to be considered to take to decide on adjuvant therapy. I think in this context,
Exactly.
CAPRA score would guide us that we are regularly following in our institute, and it is giving good results for to decide whether to go for adjuvant radiotherapy or only ADT, or whether to just wait more watchful waiting, rather than waiting till the PSA progression and patient will be apprehensive.
Exactly. So
once patient develops continence, then immediately we can go for, and we can directly start the ADT and go for radiotherapy if there are very high risk pathological features.
So Dr. Rajesh, what you're speaking exactly against radicals and raves. I'm sorry. That is how, if I have to say it in black and white, that if we just look into the PSA, and if you say that we should look into these factors, including the Gleasons, the margins, then then the PSA doesn't come into the picture. That is the conundrum. Yes, that is.
And CAPRA score would be very much useful.
Yes. But yes, the genetic markers, yes, they do deserve a mention. As Dr. Narasimha rightly pointed out, they should be incorporated like it has helped in brain, and things have changed dramatically, to put it with respect to classification. Similarly for prostate, it would make sense. It would make sense.
I think we'll go ahead now.
Jeez.
And thank you very much, Pranav.
Thank you so much.
Discussion. Thank you.
Thank you, sir.
Next lecture is by